And then here's the subserosal soft tissues. But what's happened here? It's gone, right? What's that? What is that? It's like an ulcer, right? At least an erosion and found an ulcer. So let's go higher and see if we can figure out what it is. Oops, too high. Okay. So, does anybody know where we are? Okay. Yeah, we're in the stomach. So this is the surface foveolar epithelium. Here are the little glands of the stomach. This is some fresh hemorrhage that may be procedural due to the removal of this portion of the stomach. Here's a little cystically dilated gland, which is probably a reactive process. But look here. All of a sudden, everything is gone, right? There's nothing there. It's just gone. And if we keep going and going and going, it's a very long kind of ulcer, right? Okay, it goes on forever, it seems. And then here's the other edge. So when you have an ulcer, this is kind of how it looks histologically. All the mucosa will be gone. The tissue at the edges of the ulcer will be very reactive appearing. See how these are kind of dark nuclei kind of piled up? There's some inflammation throughout here, and these glands are dilated. And that makes sense, right? You know, it's not going to be absolutely normal right next to an ulcer. So let's go a little bit higher and see what's going on. So, what kind of cells are these? Acute, chronic? Here we've got some little kind of black marbles, look very round. So those probably are lymphocytes. Here's a bunch of cells that kind of have eccentric nuclei and a lot of cytoplasm. So those are plasma cells. So this part here is chronic. And then the other thing is, I think it's kind of hard to appreciate because there's so much inflammation. But do you see all these little red blood cells here? These little red things? These are little capillaries. So the other thing that happens when you have an ulcer, the ulcer bed is made up of granulation tissue, which is just a bunch of stromal tissue with capillary proliferation and inflammation. And what's happening is the capillaries are trying to bring oxygen and nutrients to this area so it can heal. So you get proliferation. So this is an ulcer bed. And then let's look up here, if I can get it up here. What's this stuff? So here's some fibrin. This is little strands of fibrin. And here's some neutrophils in here. So if you have a cut on your skin and you get like a little serum crest, this is what that is. So this is the top of the ulcer, and then this is the bed. So this thing is huge. So if we're in the stomach, and this is a big ulcer, I think we could call it a peptic ulcer. Why not? Yeah. So this is a great big ulcer. Okay. Do we think this is neoplastic or just inflammatory reactive? Inflammatory, right, because of all the things we just talked about. And then look at this epithelium. Here's some epithelium. It's a little skinny single layer kind of trying to crawl across here, right? And these cells look very reactive. It's trying to heal. It's trying to cover itself. And it's just quite not there. But this is what happens. It'll heal and then it'll start regenerating again. Okay? And you'll always have a little scar where the ulcer was. Okay. Predisposing factors, what? Yes. NSAIDs, high stomach acidity, right, things that are toxic like alcohol. So just anything that's irritating to the mucosa of the stomach, if you take it long enough, it's going to cause an ulcer, right? Okay. Symptoms? How would this patient feel? Has anybody ever had an ulcer here? No, you haven't been to med school long enough. It's kind of like this constant. Philip, what were your symptoms, Dr. Sarah? Make them up. Well, no, that doesn't. Like epigastric, kind of a burning. So your epigastrium is right here under your xiphoid, right? So it's just kind of this gnawing, burning, You get nauseous, you don't want to eat. Does food make it better or worse? Yeah, because of course you're listing acid and all the enzymes, pepsinogen. Okay, good. Did you get better? Okay. Yes. Uh-huh. So an erosion, okay, let's go back. I want to show you something. I like this, you guys might not. So when I see this, let's see if I can find the good stuff that has the, okay, here's a bunch of, let's see if I can go down there, power. Okay, this is a bunch of inflammatory cells, right? And there's some neutrophils in here. And this pink stuff is fibrin. So when I see that, I know there's at least an erosion there, because that's what you see with an erosion only. But you may have an ulcer too, because that lies on top of the ulcer bed. So an erosion, by definition, involves the mucosa. It does not go deeper than the muscularis mucosae. An ulcer is deeper than that. They can both be painful. An erosion can easily lead to ulceration, right, because it's the same stuff that causes it. An erosion will heal a little bit faster than an ulcer. Okay? Does that help? Is that good? Okay. Okay, so don't get ulcers, they're bad. To treat them, we talked about this before, you put the patient on proton pump inhibitors, H2 blockers, take away the offending agent. Don't study for boards, Philip. Right? Stress, try to take away stress, all this kind of stuff. Okay. Complications, what can happen if you have an ulcer? It's bad enough, long enough. Hemorrhage, right? Can perforate, you're in big trouble then, right? You know, not to mention, I mean, you don't really consider things like weight loss and just, you know, loss of time at work and stuff like that, complications, but yeah, bleeding is a big one. Upper GI bleeding's a nasty one. Yes?
Do we know what percentage of peptic ulcers will go on to hemorrhage?
It's not a huge percent. It's going to be under 10%. We all have little ulcers, and we probably never even know it because our stomachs start hurting, and we start treating ourselves like we get Zantac or, you know, what is it, Prilosec or whatever, and kind of avoid whatever it is that's bothering us, and they just kind of heal. So it's actually a very low percent. And usually, a classic scenario is maybe an elderly patient who's already on aspirin, right, for the, you know, antiplatelets for MIs and stuff like that. And what if they have arthritis and they take NSAIDs for their arthritis chronically, and they just start developing multiple little erosions and ulceration, and then ultimately they have a hemorrhage, and because they're on aspirin and all this stuff, they can't stop bleeding. So that's a very classic scenario. And those are actually the patients most at risk. Okay. So we covered ulcers about to death? Okay.